wonderful introduction. So I'm Peter McPherson from the University of Liverpool. Firstly, I'd like to thank the conference organisers for the opportunity to speak in this wonderful city of Vancouver. The title of my presentation is HIV Self-Testing and Linkage in Africa. Over the past 5 years, there's been a real explosion of interest in HIV self-testing. And this IAS meeting seems like an opportune moment to provide an overview of what has been happening and where I think things are going. So I'll be speaking about what HIV self-testing is and why I think we need HIV self-testing within our armoury against HIV. I've been fortunate enough to be involved in a number of the recent studies in Africa on HIV self-testing, and I'll present an overview of some of the recently completed, ongoing and planned research. And I'll also touch on where I think the current research priorities lie. So what is HIV self-testing? Well, in the new WHO HIV testing services guidelines launched at this conference, HIV self-testing is defined by an individual performing and interpreting their own test. This may be done in private, or it may be supported by someone else, such as a health worker, a family member, or a partner. Importantly, many people conflate HIV self-testing with the use of oral fluid kits. Although oral fluid kits are perhaps the most widely studied and most convenient, blood-based rapid diagnostic kits are used for HIV self-testing and are increasingly entering development and use. Also in the new WHO testing services guidelines is this extremely helpful diagram, which shows the various methods by which HIV self-testing may be implemented, ranging from open access through to clinically restricted and either unsupervised or supervised. Through this presentation, I'll give various examples of a number of these different approaches. It's important to also emphasize, and as one of our questioners raised in the last point, that an HIV self-test is always considered a preliminary test for triage. Positive results always require confirmatory testing and linkage for care and prevention services. So why do we need HIV self-testing? Well, these are data from African demographic and health surveys. They're a little bit old now, but they emphasize that men and women's rates of recent testing for HIV are far below what is required to control epidemics, although with impressive improvements in some countries, such as Kenya. You will also note that men lag substantially behind women in all countries. These are our 90-90-90 targets that you're well aware of through this conference. Analysis of the global HIV care cascade shows that about 55% of people living with HIV are unaware of their status, meaning that current HIV testing strategies are not consistently or effectively reaching the people that need them. Moreover, there are also substantial gaps in access to HIV treatment and in ART outcomes. Novel, sustainable interventions that can flatten the cascade are required. In Africa, facility-based HIV testing remains predominantly accessed by pregnant women and by individuals with signs of advanced HIV infection, and is necessary for individual care and prevention, but insufficient to control generalized epidemics. Community-based approaches have a much greater reach and can achieve higher levels of coverage, but are often extremely resource-intensive, difficult to sustain, and challenging to link individuals to care and prevention services. Importantly, some groups, such as men, migrant workers, and key populations, are not currently well served by either facility-based or community-based approaches. So there's been a recent sharp increase in research into HIV self-testing in Africa. The HIV self-testing, or HIVST.org website, provides an up-to-date index of published and ongoing HIV self-testing studies. Most studies have been studies on opinions and attitudes, or qualitative studies, with smaller numbers of cross-sectional implementation studies and a handful of randomized controlled trials. Key populations are also underrepresented compared to other groups, despite being an ideal target group for HIV self-testing. Studies have been concentrated in only a small number of African countries, with most conducted in Kenya, Malawi, and South Africa. One of the first studies to show the potential of HIV self-testing was conducted amongst health workers in Kenya, where 90% of nurses took up the offer of an oral self-test kit, and 85% tested themselves at home. In Cape Town, South Africa, an innovative supervised HIV self-testing strategy supported by an internet and cell phone-based app had extremely high uptake and was well liked by participants. And a recent mathematical modeling study from Zimbabwe using data from Zimbabwe showed that widespread community implementation of HIV self-testing could be cost-saving and avert a substantial number of DALIs under certain conditions. So since 2010, our research group led by Liz Corbett has been conducting a series of studies into HIV self-testing in Blantyre, Malawi. Malawi is one of the poorest countries in the world, with an adult HIV prevalence of 10.8%. It also has an extremely well-regarded national HIV program with considerable achievements on very low resources. Blantyre is in the southern region of the country, and it's the main commercial centre. Adult HIV prevalence in the city is 18.5%. So we firstly set out to describe the need for new approaches to HIV testing and linkage in a series of quantitative and qualitative studies. So this shows a portion of the HIV care cascade for primary healthcare clinics in the city of Blantyre. Among nearly 20,000 consecutive adults attending primary healthcare centres, only 13% completed HIV testing. Pregnant women were well served by the PITC approach, but men and non-pregnant women reported that they had waited until they had symptoms of advanced infection before they decided to attend for a health facility for a test. And this emphasises the need for accessible community-based testing approaches. Major barriers to linkage to HIV care included a failure of health workers to promptly complete ART eligibility assessments, and the difficulties and high costs experienced by patients who had to access CD4 cell counts through the city's central hospital. To begin investigating alternative strategies to improve access to HIV testing, Liz Corbett and Ogu Choko conducted an initial feasibility study. So in 2010, 298 adults were randomly selected from households and from community groups in Blantyre, and were offered supervised self-testing using OraQuick in the presence of a counsellor. Uptake was extremely high at 92%, and HIV self-testing was very popular, with the large majority of participants choosing collection of an HIV self-test kit from a neighbour as a preferred next HIV test. Sensitivity, specificity, and accuracy were also high, despite 8% illiteracy in the community. However, 10% of participants made mistakes or required additional help, emphasising that in this community, a semi-supported model of care was required. Having demonstrated initial feasibility and acceptability of the HIV self-testing model, we went on to evaluate effectiveness in 2 linked cluster randomized trials. This is Liz Corbett's HIT TB HARD trial. In this study, 28 neighbourhoods in Blantyre, comprising of nearly 35,000 adults, were randomly allocated to receive access to facility-based HTC alone, or the additional offer of HIV self-testing delivered through neighbourhood volunteers. The study team are currently conducting analysis of the trial outcomes, but I'm able to report on 2 years of HIV self-testing outcomes today. This map shows the 28 neighbourhoods allocated to the HIV self-testing intervention, highlighted here in red, or to the facility-based testing alone, highlighted here in blue, as well as the location of the 3 public health facilities offering HIV care and testing in the study area. Within each intervention neighbourhood, highlighted here in purple, HIV self-testing was offered from a trained volunteer counsellor's house. You can see here Zebron's house is highlighted by the pinprick. We used the OraSure OraQuick test, and adult residents could collect 1 test kit per year from the neighbourhood counsellor. Participants were asked to test in the privacy of their own house and to return the used test kit with a self-completed questionnaire to a locked ballot box at the counsellor's house. They could report their self-test result to the counsellor and receive results-based counselling and linkage, or not report the result and receive generic oral and written advice, including a self-referral card to access HIV services at the clinic. So this figure shows uptake of HIV self-testing in the 14 intervention neighbourhoods by age group and sex during the first 12 months of availability. And as you'll see, HIV self-testing was extremely popular, with uptake rapid over the first 6 months. Overall, by month 12, 76% of the entire adult population had self-tested, with the highest uptake in young women, up to 100% in the 16 to 24-year-old age group, and particularly amongst young adults. Importantly, 35% of users had never previously tested for HIV. In the second year of HIV self-testing availability, uptake was even more rapid, and the proportion of people testing for the first time was substantially lower. And this shows high readiness to retest in this community. All participants who self-tested were also asked to self-complete and return a questionnaire. As in the previous pilot study, self-testing was by far the most popular choice for the participants' next HIV test. A random sample of participants were also revisited by the study team and retested following a confirmatory diagnostic algorithm. Overall sensitivity was 93.6% and specificity was 99.9%, lower than in our supervised pilot study, but comparable to the US FDA's evaluation in the hands of intended users. Importantly, and echoing a number of other recent studies and reports, was the fact that 4 out of 9 people who self-tested falsely negative reported that they were taking ART at the time of their self-test. This questionnaire also asked in detail about adverse events. In total, 2.9% of self-testers reported that they'd been coerced into self-testing. Men and people who tested as couples were significantly more likely to report coercion. However, when we delved into these data in greater detail, we noted that those who said that they had been coerced into testing still had very high levels of satisfaction with HIV self-testing. Our qualitative studies suggest that rather than coercion, what in fact we saw was a phenomenon of initial reluctance followed by a gentle nudge from a partner and high rates of satisfaction following the completion of self-testing. We also recruited 4 key informants in each of the 14 neighbourhoods who recorded adverse events and did verbal autopsies for all people who died during the 2-year study period. In the first year of availability, where we have data currently available, there was only 1 suicide amongst a person who had not self-tested and no episodes of intimate partner violence or murders related to HIV self-testing. Some really interesting qualitative work from Nick Desmond and Moses Kamwenda shows that HIV self-testing was popular amongst couples, but didn't lead to sustained behaviour change. Oops, sorry. We also noted that as reflected by our uptake data, older individuals did not perceive themselves to be at risk of HIV and therefore did not see the need to self-test. We feel that modified, age-appropriate approaches and messages are clearly required. This slide shows our estimated rates of linkage from HIV self-testing into care. Of the 13,966 individuals who self-tested during the first year of availability, 12% reported a positive self-test result to the counsellor and were referred to clinics. 56% of those not already on ART were recorded as attending a study clinic, 80% of whom had a CD4 count measured. However, participants could also directly access clinic services without going through a counsellor, so we believe that these linkage results represent a conservative minimum. To try and improve upon the uptake of ART following HIV self-testing, we conducted a second cluster randomized trial. So we took the 14 neighbourhoods that were allocated to receive HIV self-testing in the main trial and randomized them again. We believe that this was the first ever second stage cluster randomized trial. So in this second trial, neighbourhoods received either access to facility-based HIV care alone or the additional option of receiving home initiation of HIV care, including ART. The trial endpoints were uptake of ART at 6 months, uptake and reporting of positive HIV self-tests, and loss from ART after 6 months. This shows what happened in those 7 intervention clusters. Participants who self-tested HIV positive could request that a nurse on a motorbike visit their home and conduct ART eligibility assessments and TB screening at home. If they met national ART eligibility criteria, they could initiate ART at home and received a 2-week starter pack. They then an appointment was made for them at their local primary healthcare centre, and they were linked into care to continue ART. So we published these results in JAMA last year. In analysis of the primary trial outcome, at six months, 3 times as many adults had initiated ART, where optional home initiation of care was available, compared to where only facility-based initiation of care was available. This table shows the primary and secondary trial endpoints. The effects of optional home initiation of care remained highly significant even after adjusting for potential confounders. There were no significant differences in rates of uptake of HIV self-testing between groups. However, where optional home initiation of care was available, participants were significantly more likely to report a positive self-test result to counsellors. And we believe this represents increased demand for home-based HIV care and ART initiation following a home self-test. When we followed up ART initiators for 6 months in the clinics, there was no significant differences in rates of loss from ART, although these are small numbers. Hendy Maheshwaran has a late breaker poster at this meeting reporting on the economic analysis of HIV self-testing in our Blantyre trials. So he recruited cohorts of HIV self-testers, as well as individuals undergoing HIV testing at the 3 health facilities in the study area. Overall, the total societal costs of HIV self-testing were significantly lower than through the facility-based approaches. Participants undergoing HIV self-testing incurred negligible out-of-pocket or own costs. And the main driver of the HIV self-test costs was actually the test kits themselves, which cost about $4.40 in our study. Our main conclusion of this analysis is that if the costs of HIV self-testing kits were to come down, substantial cost savings could be made. So that was a very brief run-through of some of the work that we've been doing in Blantyre over the last few years. Although these studies show that HIV self-testing has a high potential as a complementary approach to existing facility and community-based approaches, there are a number of research gaps that need to be addressed. Firstly, as evidenced by Hendy's economic data, there's a real need to develop and to evaluate new HIV diagnostics that can be used for HIV self-testing to stimulate the market and to bring down costs. This needs to be supported by formative and operational research into what materials can improve ease of use and accuracy in the hands of intended users. More evaluations of HIV self-testing delivered through a wider range of settings, populations, and models are required, especially amongst men, older individuals, and key populations. And a wider range of linkage strategies need to be evaluated too. Finally, very few African countries have successfully included HIV self-testing within national HIV guidelines, although a number are currently considering this. A clear need exists to improve policy and regulation in the region. Some of these priorities may be addressed by ongoing and planned studies. 4 randomized controlled trials are currently planned or ongoing, looking at the effectiveness of index-based approaches to HIV self-testing, where young women, women receiving antenatal care, or individuals registering for TB and HIV care are asked to distribute self-test kits to their partners. At this meeting, Harsha Thiamurthy and colleagues have a late breaker showing impressive data from Kisumu in Kenya. Fewer studies are designed to address some of the other research priorities. Sunaparelia Mavadzenge and colleagues at this meeting have a poster discussion looking at how self-test materials can be best improved to improve accuracy. And the largest study is the PSI Unit STAR study, which aims to address a number of the major outstanding questions about HIV self-testing. STAR aims to stimulate the market for HIV self-testing in Africa by undertaking a series of studies and implementation and regulatory activities in Malawi, Zimbabwe, Zambia, and South Africa. In the first phase, PSI will implement the delivery of 3.6 million HIV self-tests with a number of nested diagnostic accuracy studies, cluster randomized trials to address linkage interventions, and modeling policy and regulatory activities. This study is due to commence this August. So as you can imagine, a large number of individuals have contributed to this presentation and this study is reported. I'd particularly like to acknowledge Liz Corbett and Ogu Choko for the really groundbreaking work they've done. I'd also like to thank Cheryl Johnston and Rachel Bagley from WHO for the support, and also the Department of HIV at the Ministry of Health of Malawi, and especially the community members and volunteers in Blantyre. Thank you.